Hi, good morning. I'm Selena De Borja.
And I'm Tom Clino.
And we are the course chairs for this year's program. And we'd like to welcome you all to the 2024 Pediatric Musculoskeletal and Sports Medicine Conference. Dr. Rhonda Watkins is also one of our course chairs, sent her regards while on leave. We are very excited to share these 2 days with you all, learning on a broad range of musculoskeletal and sports-related topics. We have speakers from various pediatric specialties, including orthopedics, sports medicine, rehab medicine, endocrinology, and radiology. Today, we'll have multidisciplinary case presentations that include physical therapists and advanced practice providers. And tomorrow, we'll have dynamic workshops led by our physical therapists and athletic trainers.
All right, so I got the fun stuff. To get started, we have a couple announcements. This morning, a speaker survey will be sent out via Qualtrics. Please complete the survey by the end of the course. To claim CEU and CME credit for this course, you'll receive an email tomorrow afternoon with a link to complete the online overall course evaluation, and you will have 30 days to complete that. If it's not completed within 30 days, we will, have to talk to you. But most importantly, we want to thank our support from our exhibit sponsors. We have Alexion, Enovis, Kiowa, Chiron, Siemens Healthcare, and Bald. Please make sure you take the time today, go out and talk to them. They have lots of good products and information to share with you guys.
All right, so I have the pleasure of introducing our speakers for today. We'll start the morning with a session on spine deformity. We have Dr. Mohammad Diab as one of our speakers. He is a pediatric orthopedic surgeon. He did his orthopedic surgery residency at the University of Washington and pediatric orthopedic surgery fellowship training at Harvard. He is world-renowned in the field of pediatric orthopedics and specializes in hip and spine conditions and is one of our innovators in spine tethering. Welcome, Dr. Diab. We also have Dr. Ishaan Swarup, who's one of our pediatric orthopedic surgeons. Dr. Swarup did his residency at Hospital for Special Surgery in New York City, fellowship at Children's Hospital of Philadelphia. He has special interest in scoliosis and other spinal disorders, hip conditions, and traumatic injuries. At UCSF, he serves as the Director of Pediatric Orthopedic Trauma and is the Associate Program Director of our Pediatric Orthopedic Surgery Fellowship. And last but not the least, we have Danny Keller. Danny Keller is a physical therapist who earned his degree in the joint program of UCSF and San Francisco State University. He is a member of the American Physical Therapy Association, through which he is certified as an orthopedic clinical specialist. Danny has been involved in multiple research projects, including the development of an exercise program for the NASA astronauts with low back pain. So we'll start this session with a talk from Dr. Swarup.
All right. Thanks, everyone. Thanks, Lena, for that introduction. Good morning, everyone. I'm Ishaan Swarup. I'm an orthopedic surgeon here. I work mostly out of our Children's Hospital in Oakland, but also do work at our Mission Bay campus at Walnut Creek. My voice is slowly recovering, so I'll try to hopefully last through this session. But apologize in advance if I have to take a little bit of a break. So I thought I would first start off by just doing a little general introduction about what is scoliosis and what is kyphosis. And then Dr. Diab's going to give a little talk as well on a more specific indication, a more specific procedure for scoliosis. And then we'll talk more about back pain as well. And at the end, we'll have some time for some cases to discuss kind of what we do for decision-making for patients that present with spinal deformity. My disclosures are listed there. None of them are relevant to this talk. So today, or this morning, just for the next 15 to 20 minutes, we'll go over some definitions of scoliosis and kyphosis. We'll specifically talk about idiopathic scoliosis, which is oftentimes the most common thing we see as spine surgeons, and you guys also see in your world. We will talk about some of the other types, which include congenital scoliosis and neuromuscular conditions. I'll also spend a few minutes just talking about kyphosis, since that's oftentimes a common complaint that parents present with, and then also we get referrals for. And then lastly, I'll try to leave you guys with a couple of resources and education materials that you could use in practice. So in general, scoliosis, as many of you know, is a three-dimensional deformity. We think of it oftentimes as lateral curvature of the spine in the frontal plane, but really you got to think about it in 3 dimensions. And then, the analogy again is twisting of the towels. It's more of a rotational deformity than a true lateral curvature of the spine. It can be classified as many different types. The most common classifications that we use are idiopathic, congenital, neuromuscular, those that are related to myopathies or syndromes, and then compensatory. Compensatory ones being ones that are not true scoliosis, but maybe related to, say, a leg length difference and present as apparent scoliosis. And then kyphosis refers to the sagittal plane. So the lateral plane has more, we would generally have normal cervical lordosis, thoracic kyphosis, and lumbar lordosis. And so thoracic hyperkyphosis is oftentimes seen in patients, and this can be either postural or structural. And so the most common structural type of kyphosis that we see is Sherman's disease, and I'll talk a little bit more about that. So idiopathic scoliosis, the etiology is unknown. However, it's likely multifactorial. We do think genetics plays a role, and it does tend to run in families. It's classified according to the age of onset. So if you think about, again, broad categories of scoliosis, idiopathic scoliosis being the biggest category, it breaks off into 3 different groups based on the age at the time of diagnosis. So if you're younger, it's infantile, kind of 3 to 10 year age group is juvenile, and 11 and older is adolescent. So the prevalence of scoliosis is actually quite prevalent in the community. It's about 2 to 3%, but very few patients have curves that are greater than 20 degrees. And so very few patients oftentimes get referred and get seen for this. Girls tend to have idiopathic scoliosis more likely than boys, specifically curves that are greater than 30 degrees. And then as you can see there, it's about a 10 to 1 ratio for girls versus boys for greater than 30 degree curves. So in the clinical evaluation, what do we typically do? So oftentimes the most common complaint from caregivers or for the patient themselves is a cosmetic appearance, right? So it looks different when they look in the mirror, or it looks different when they go to the pool or to the beach. And then obviously from the primary care screening exams, this is the forward bend test that most pediatricians will do. Then there's the rotational assessment that can also be done, which will with a scoliometer, which can clue you in. The history and exam is important since oftentimes it is a diagnosis of exclusion. Since it's idiopathic, we don't know the cause, so it's important to screen for other things. The physical exam, the things that we typically look at is obviously inspection is important. So the things that we look at as orthopedic surgeons is shoulder height, waist crease asymmetry, pelvic height. And so the reason for those things is it kind of helps you get a sense of how bad the deformity is. And then, for example, looking at the pelvis, it gives you a sense of whether there might be a leg length difference as well that could be contributing to their spinal deformity. Skin exam is important. And so for that, we're looking at, again, going back to some of the non-idiopathic causes, right, of scoliosis. So capital lay spots, skin changes that might suggest a syndromic condition are important to look at as well. And then a neurologic exam as a screening baseline is important. So in terms of what do we do for measuring rotation, admittedly, most of us in spine surgery don't use a scoliometer anymore, but in the primary care setting, I think it is very helpful. And so this is where, you have a patient bend forward and add them forward bend test. You place the scoliometer on their back and you try to see what is the maximal amount of rotation that you can see. And typically the referral is warranted if the measurement is greater than 5 to 7 degrees, which roughly correlates to about a 20 degree curve. In terms of imaging, the things that we try to do, so, there's kind of, I would say in technical practice, there's 2 ways patients come in. One is they come in with x-rays, or the other is they get x-rays in our facility. I would say either is fine, but if you are going to get the x-rays in the community, make sure you're sending the child to a facility that does standing scoliosis x-rays and knows how to do those well and stitch the x-rays together well. And so standing high quality PA radiograph is really important. Lateral radiographs are important. We determine the Cobb angle measurements. Oftentimes, a radiologist will give you measurements if you're doing this by yourself. But for us, we'll all do our measurements individually as well. There can be some variability, so it's important to understand that part. Up to 5 degrees of variability is quite common in measurements. And then skeletal maturity assessment is another thing that we try to ascertain from these x-rays. And we can do this by looking at something called the Risser sign, which is a proxy for skeletal maturity that can be based off the iliac apophysis or the iliac crest, as you can see on the image at the bottom. And now, what are the indications for MRI? These are really variable and somewhat controversial. I would say it certainly is indicated for certain diagnoses. So there are certain other syndromic conditions, again, not idiopathic scoliosis, but in those conditions, you would get an MRI. So for example, if a kid has Marfan syndrome and also has scoliosis, we often get an MRI to look for dural ectasias. And so those are the specific conditions that we will get an MRI oftentimes. There are, in going to specifically for idiopathic scoliosis, oftentimes in the juvenile idiopathic category group, we will get MRIs for that group because some studies suggest that up to 20 or 25% of them will have some kind of neural axis abnormality. Exam findings, so going back to the neurological exam, oftentimes we'll do this in our initial evaluation, but if there's asymmetric reflexes, atypical concerns, pain, which is usually not associated with idiopathic scoliosis, those things might clue us in, and we oftentimes might recommend getting an MRI if those are kind of more significant findings. And then there are some what we call atypical curve patterns. So generally speaking, idiopathic curves are right thoracic curves. So oftentimes if we see things that are different than that, so for example, left thoracic curves or short angular curves, those are things that are more concerning, and we would oftentimes get an MRI for those patients as well. So what do we do for treatment? So first of all, why should we treat scoliosis, right? So I think first and foremost, at the end of the day, it's about preserving function for the patient. And so curves generally less than 90 degrees will not cause any cardiopulmonary issues. And thankfully in North America, it's rare to see curves greater than that in idiopathic patients. But we do want to prevent progression, and so that they don't progress to curves over 90 degrees later in adulthood. Pain is another potential indication. So again, may not present with pain, especially when you have in adolescent category where the curves are not as severe, but that does become a more significant concern in older patients as they get into their 40s, 50s, 60s, where the curves become bigger and they develop degenerative scoliosis. And then deformity and cosmesis, even though obviously that's not an indication for surgery, that is oftentimes a major concern from families and the patient themselves. So options include observation, bracing, and surgical management, and that's all really based on the magnitude of the deformity and how much growth the child has remaining. And so the real kind of holy grail of all of this is figuring out which curves are going to progress and which ones are not. So the risk of curve progression really depends on the patient's sex, the curve magnitude they present with. So the higher the curve magnitude is when you present, the higher the chance it's going to progress. And then remaining skeletal growth, which is probably the most significant risk factor for progression. The table on the right, I'll just I know it's a little blurry up there and it's a little small, but this is from a study out from the University of Iowa, which is kind of the best natural history data that we have, which shows that curves that are greater than 45 to 50 degrees are the ones that tend to progress into adulthood. And that's the reason why we oftentimes use that as our threshold for surgical management. So observation is recommended mostly in patients that are skeletally immature with curves less than 25 degrees. The frequency of monitoring these curves really depends on the patient's age and growth potential. So when children are younger, premenarchal, we'll generally watch them more closely. If they're older and postmenarchal and more skeletally mature, the frequency of follow-ups will be less frequent. And then the curves, just like we talked about, the ones that do progress after skeletal maturity are really the ones that are over 50 degrees. And these are the ones that tend to progress by a degree a year. And so that's the reason why we use that as our threshold for surgical management. So bracing. So just like I was saying, less than 25 degrees, we typically observe. Curves above 25 all the way to 45 degrees, we tend to think about using a brace. And so the key things here that I'd like to kind of talk about is the point of bracing is not to correct the scoliosis. It can't do that. What it does, it stops progression. So that's really important to understand, that it stops the curve where it is. It is a commitment. So even though bracing sounds like it's pretty easy, it's not. We're oftentimes asking families and patients to wear this brace for 18 hours a day, which is a very significant portion of the day. And so it is a commitment. And that's why this decision is a little bit more of a shared decision making when you're talking to families. Compliance is key. So the brace only works if you wear it. So there's good data now suggesting that the efficacy of the brace is it's kind of minimal until about 12 hours of wear. And then after 12 hours of wear, all the way to 18 hours of wear, the efficacy kind of continues to increase more in a linear pattern. And then again, in about 18 hours of wear, it starts to flatten out again. So that's the reason why we recommend wearing the brace for about 18 hours a day. And then periodically we'll get x-rays to monitor for effects or progression. And that's just to make sure the curve is staying where it is. So what about surgery? So surgery is typically reserved for children with progressive curves and curves over 50 degrees. And so the goal there is to stop progression and achieve a balanced spine. There are various techniques that have been described, but in North America in 2024, the most common way to do this is through a post-spinal fusion. And then the outcomes of this are relatively good. I mean, we've been doing this for over 30 to 40 years now. The modern day instrumentation we use has been around for over 20 years now. And so there are some shortcomings, obviously, which are obviously beyond the focus of today's discussion. but overall patients do quite well with a fusion. So now getting back to you guys, when do you refer patients to us? So obviously if the screening is positive and the Adams 4 bend test or with a scoliometer, that's a good reason to refer. Now, if there's concern for scoliosis, especially in families that may have a significant family history of it, it's a good reason to check and to refer. And then for syndromes or conditions associated with scoliosis, this would be things like connective tissue disorders, neurofibromatosis, things that are well known to be established with scoliosis would also be reasons to refer. So this algorithm on the right is something that was put together in JAMA a couple of years ago, which I think it does a good way from a primary care perspective of how to evaluate these patients and when to refer. And so when you refer these patients, oftentimes these patients wait, right? Because they come to see us and it can be a 1 to 2 month wait. So what can you do in the meantime? Getting x-rays, I think that's okay. Again, as long as you're referring them to a facility that does scoliosis x-rays, and then providing them with some patient education, which I'll talk about in just a second. And then the other place where I think we all work together, we work together as a team in many parts of this, but the place where I think we all work together a lot, especially in the patients that undergo surgery, it is a significant undertaking and it is a team effort. And so preoperatively, oftentimes these patients will get anesthesia evaluations. I oftentimes will send them back to you guys to have them get a preoperative medical examination as well. Lab work is done, skin evaluation. Those are the things that we kind of do together to make sure that surgery goes as safely as possible. And then going back to what I was saying about surgery, this data is actually now a couple of years old, but you can see the most common complications that we see with posterior-spinal fusion is infection. So that is still a consideration. The risk nationally is probably right around 1%. And thankfully at our institution it's a little bit lower than that, but it's still not an insignificant number. And so that's the reason why it's important to evaluate the skin, make sure there's no other, coexisting issues that could put them at risk for infection. Neurologic injury, obviously we think about that a lot in spine surgery, but the risk of that is quite low. It's really less than 1 in 1,000. And then the last major one that we think about is instrumentation related. And again, those can happen, but the risk is certainly small. So just in the last 2 or 3 minutes here, I'll just go over some of the other types of scoliosis. So congenital scoliosis is another important topic. So again, this is different from idiopathic scoliosis. Congenital scoliosis refers to abnormal development during growth and development. So typically during about 6 to 8 weeks of gestation, when the spinal column is developing, this is where the abnormality occurs. It can be either a failure of formation or segmentation. So formation is basically the vertebra doesn't form, and segment means separate from the adjacent vertebra, or it can be mixed. For this one, the take-home messages are, it is important to look for some other abnormalities. So your GU and cardiac systems are developing around the same time embryologically. And so oftentimes it's important to screen these patients with a cardiac echo or a renal ultrasound. And then, what do you do for these cases? And it's really controversial. The bracing we sometimes will use, but the indications are very unknown and the efficacy is unknown. So for younger kids that are developing progressive curves with congenital scoliosis, we will use that oftentimes as a temporizing measure, but oftentimes not definitive. And then if they do have a lot of progression, especially in the sagittal plane, but also in the coronal plane, then those are the ones we think about surgery, which again is a little bit beyond the scope of today. And then neuromuscular syndromic scoliosis. So this is more common in patients with things like with conditions such as cerebral palsy, muscular dystrophies, and certain syndromes. We think this is likely related to muscular imbalance, spasticity, which results in imbalance. And most often the complaints that families come with is difficulty of care or sitting balance. Oftentimes the patient is, tipping over in their wheelchair and not able to sit up straight. There's ways to kind of help with that from a non-operative point of view, try a brace, try modifications of the wheelchair. But at the end of the day, when the curve gets to be 90 degrees, it's going to be a difficult challenge to deal with non-operatively. These are a little bit different. So going back to kind of typical curves, atypical curves, these are oftentimes long C-shaped curves. And then surgery, again, we use that 50-degree threshold, but I would say most of us will try a lot of non-operative things first. And oftentimes when we're operating on these, they have more significant curves and more imbalance. And that's the times we'll operate on these patients. The important thing to know about neuromuscular kids is they have a much higher complication profile than idiopathic scoliosis. And so these are the ones that, really need a lot of perioperative optimization to ensure that we have low complications. And then kyphosis, oftentimes is a cosmetic concern. And then for kyphosis, it kind of breaks into 2 categories. Postural, which is flexible. So, this is oftentimes cosmetic and it's It's really more of a visual thing, and you tell a child to sit straight and they can sit straight. We oftentimes manage this with just reassurance, and if you're really concerned, you can send them for physical therapy for some hyperextension exercises. But structural kyphosis, this is more rigid kyphosis. These are the ones that oftentimes will be worse actors, so to speak. And so these are the most common type we see in North America is something called Sherman's disease or Sherman's kyphosis. There's a technical definition of it, which is based off of x-rays, which is wedging of 3 consecutive vertebrae by 5 degrees. And it's rigid. So these are the ones that you tell the child to try to sit up straight and they can't. So in physical exam, you try to correct their kyphosis and they still have some residual kyphosis despite trying. You can, treatment-wise, you can try some physical therapy, bracing, but oftentimes surgery is indicated, especially for kyphosis over 70 degrees and patients that have significant pain. And then lastly, so what are some resources and educational materials that we can offer you? So the Scoliosis Research Society, which those of us that do spine surgery are members of, they have a great web page all the way from kind of clinicians, but also to patients and for caregivers. So I oftentimes refer patients to that. The Pediatric Orthopaedic Society also has some great information. AOS has some great information, which is our academy. And then at Children's here, we also have a lot of great resources that our team has put together, which is really helpful while, if you have to give something to families while they're waiting. A lot of them are available in Spanish as well. I'll wait on this until the end, and so I'll hand it off to my colleague, Dr. Diab.
We'll just save the questions at the end of all their talks.
Yeah, that's all right. Oh, no, this is. Hi. I'm gonna find this way. Great. Hi, everyone. I was asked to talk at a European spine meeting, fusionless surgery, with that specialized. And then I thought to myself, we talk in Portugal and then we don't talk right here. So I thought I'd talk about this. It's a very focused thing, but it's new, not so new, but new-ish, and patients ask about it. And it's, I think, good for you all to know what we're doing, what we're up to, and where we're going. So this is something called tethering. I was thinking of what Dr. Swarup was talking about, the procedure, how long we've been doing fusions. And I was telling Selena that the first publication for a spine fusion was in 1911. And it's 100 years later and we're still doing spine fusions. Because it works, it's a good operation. But I wonder if you all can think of things that you are doing now that you did 100 years ago in pediatrics. Probably not very much, right? I mean, it's a pretty amazing procedure that it's still so durable. But we're trying other things so that we don't take away the movement. So when you do a spine fusion, how much can the patient move from the part that you fused? Somebody say something. From 0 to 100 of their normal movement, how much can they move from the part that you fused? Zero. Yeah, that's crazy. I think that's crazy. And then if you think about the word vertebra, okay, it comes from the Latin to turn. That's why we talk about version and all that. And so we take a bone that's named for its movement and we just knock it out. All right. So it's always been something, even when I was in training, I would think to myself, this is so sad, because you go in there and you just muck up all the bones and you stick them all together. And in our world, we think cartilage is gold, and we're just cutting out all the joints of these pristine patients. So anyway, this is an effort to try to not fuse the spine. It doesn't work great, but it's not bad sometimes. But just know about it. And my disclosure is that somebody asked me to try to help them develop a magnetized version of this, but it's not going anywhere. I don't get any money for it. But this is the concept. If you're on a chariot and you're the charioteer and you have the reins of 2 horses, okay? If one horse runs faster than the other, are you going to turn? You're going to turn, right? And the way you control it as a charioteer is you grab the rein and you pull back so you can keep going straight. So if you've got a curved, I agree with Dr. Swarup, but this is a twist, not a curve. I wish we could say twist, but it's just too late. We call it curve. But if you've got a curved spine and it's going this way, we think in a very simplistic way that this side of the spine is growing a little bit faster. The bone is running a little bit faster. So maybe if we could just tether this side of the spine, but not this one, we leave this horse alone, that we might be able to let it grow straight. So that's the idea. But one thing to note is you need growth. So you're not doing it for a 30-year-old, right? You're doing it hopefully for an immature 13-year-old. And we know this because this is what we do. And we do this pretty routinely. Can you guys see that? So that's a growth plate, growing child, growing spine. And if you put a tether, the screw is just a tether on one side where the physis is, but you let the other side grow, it's magic. They just grow straight. So that's what we're hoping for. And it's not new. To quote King Solomon, there is nothing new under the sun. This was done back in the 40s and 50s, but it failed miserably. But the idea there is that's your spine. You put a staple, a piece of metal that bridges on one side and won't let it grow. And then maybe it will grow on the other side and straighten out. So this paper came out in 2006, and I read that and I went, oh, bracing doesn't work for this group of patients. I tried to underline it for you. The under 10-year-olds who have a 30 or more degree curve, brace in this series, they all failed. The treatment failed them. They didn't fail anything. The treatment failed them. Bracing didn't work and they had a fusion. And when we read papers, I'm sure it's the same with you guys, we believe certain places more than others. And D'Amelio's group are excellent. These guys, when they write something, we all read it. But that's what got me thinking was maybe this is a group of patients that isn't going to benefit from a brace. Because like Dr. Swarup told you, once they get to be about 25, 30 degrees, put them in a brace. And we hope that we can arrest progression, not straighten them out, arrest them. But this group doesn't work. So the under 10-year-olds, more than 30 degrees. And so we started doing this. We reinvented the procedure from the 50s with new technology, and it seemed to work okay, but not great. And we did a biomechanical study to show that you still had motion. So not a fusion, just put it in the metal, but it would wiggle, it would prevent growth on one side, but let the spine move everywhere else. And then we came up with this, and I don't know if you know this, Dr. Swarup, look at, I think Cahill's on that, right? Yeah, right? This was the early days, right? When he was with Betts at the Shrine. I think he may have been a fellow here, I can't remember. But anyway, it's one of Dr. Swarup's colleagues in Philadelphia. But anyway, so we tried to come up with criteria. So very narrow criteria. Enter the current, so just so you guys know what's available to your patients. Now we've moved from a metal staple to a screw in the bone, and every screw is connected with a piece of rope, essentially. Okay, it's not fancy technology. Okay, you can get this at Home Depot. You go buy a screw and put a rope, and it's exactly the same. The only difference is at Home Depot, the screw costs 50 cents. This costs $5,000. Okay, and I just think that's insane. I mean, I don't know what you guys think, but I think that's insane. And I've actually retreated from this procedure. Even though I was early on in the procedure, I've sort of retreated because I think the cost is overwhelming. It's just too much. It's $5,000 a screw. The piece of rope is $5,000. And it's just Dacron. You can actually get that at Home Depot. You can get Dacron. You can go buy a spool of Dacron for a few dollars. And here it's $5,000 for that. So that is one of the issues, okay, in this procedure, but we have it. So it's surgery, you put screws in the bone and you connect it with a cable on the outside part, the so-called convexity, and hope that the concavity continues to grow and straighten. And when it does work, it's magic. okay? Which is why I keep trying, even though there are many fails. I'm not here to advertise it or promote it or sell it. It's got its indications, but it doesn't always work. But when somebody comes in like this, who's been braced for 6 years and is still progressing, so he started getting braced at 5 years, at 6, and then he came at 11 and it was 40 degrees. So you could just see the x-ray slowly getting worse. So we did that and he just straightened out. And the hope there is that his spine will at least move partially. He's still got a piece of rope there, so he can't bend in one direction, but he can at least rotate and he can bend forward and bend back. So when it does work, it's really nice. The screws are in there, and then the cable you can't see that's connecting them, but holding his curve. We do it open or with a telescope. We sometimes do it from the back. I'm sorry to show you surgical pictures, but sometimes I feel like you should know what we do to your patients. That's what we do to them, okay? It's not subtle. But we go into the chest and do it from the front or go in the back, which I think is a little bit easier. I've started trying to do that. And when we presented this back in 2016 at our academy, I just got assailed by everybody. They were just so mad at that anybody would do it from the back. But it's not a bad procedure. Like yesterday, I did one of these and the patient goes home the same day. So again, for your patients, when they come in for a fusion, we beat them up. They are in the hospital, they are miserable. Yes, we get them moving and loss of rah-rah and stuff, but they're not happy and it takes them forever to recover. If we can change this paradigm and do it as an outpatient procedure with so little blood loss, that would be great. So these are some of our motivations that we keep trying to make what we do a little better for the patients. But there are a million questions. I'm actually going to stop because I don't want to overwhelm you. I had all these questions that I was going to go through with you guys, but I'm going to stop because I think the question answer at the end are better. But just know that we're trying to come up with fusion alternatives that are a little bit kinder to the spine and then hopefully kinder to your patients. So I'm going to stop now.
All right, I'm going to try to follow that speaking voice, but I don't know that I can actually keep up with it, to be honest. I felt like I was listening to a podcast. I am Danny Keller. So I work actually across the bay most of the time at Mission Bay. So I'm here to give you guys a little bit of information on how we treat pediatric low back pain. Obviously, it's not a common thing, right? And it shouldn't be a common thing. It's becoming a little bit more common, unfortunately, but we'll talk a little bit about that. And then I'll talk a little bit about kind of how we can connect this back to some of the stuff that our earlier speakers spoke about. So I'll do my best to get my nice low speaking voice going. I don't have any disclosures for this talk. All right, so what's the etiology of pediatric low back pain? If you look at the studies, there's a pretty wide variability in what they rate as pediatric low back pain. There's a lot of reasons for this, kind of the definition of back pain, the population that you're looking at. There's a lot of variability within it, but we know that it's not a super common thing in terms of what we see in the clinic. It's about 10 to 25% of athletes, which is probably where we see it the most. The most common sports to see it in are things like football and gymnastics. You can pretty much assume why if you watch gymnastics. I don't know how they bend backwards that much, but it's interesting. And we see it more in females than males. Again, you see a lot of these statistics. Ishaan talked about it earlier in terms of females being more prevalent with scoliotic changes. And so we know that there's a similar effect with the epidemiology of just generalized low back pain. So I was trying to figure out how to best give this talk to you guys as mostly primary care physicians. So I decided I was going to kind of break it down into the basics and then give you guys a few of my favorite exercises at the end that you can hopefully provide in the clinic to some of these patients. We see a lot of patients that come in and they say, my back hurts, and we see them once or twice, we give them some exercises, they do great, right? The pediatric population is very different than the adult population. So hopefully we can give you guys some good basic patient education pieces and then some exercise pieces just to take with you as you go. So I wanted to start kind of breaking it down, obviously, into how we talk about back pain. So the difference between mechanical low back pain with radicular symptoms, and then constant low back pain. I think these are the kind of three main pieces that you want to look at when a pediatric patient comes into the clinic. So mechanical low back pain being more localized to the lumbar region. You may see some slight radiation of that pain along kind of the paraspinal region or into the torso. Generally, it's going to be worse with extension plus or minus rotation. So these are the most common types of mechanical low back pain. And then typically there's going to be tightness that's relieved with flexion. So they're going to feel good bending forward. They like to bend down, touch their toes. Those are going to be those types of patients where they go, oh, that feels tight, but it actually feels good, right? Low back pain with radicular symptoms. Now we're getting nerve root involvement. So that's going to be pain that involves the lumbar nerve root in that region. So in that lumbar spine generally, as well as distal sites along the lower extremity into the hip. And it's generally going to be connected with the ags and eases. So if they don't like to sit, then that's going to increase the pain in their leg and their low back. One thing that isn't always perfect is they don't always have back pain with this, right? Someone may come in with hamstring pain or calf pain, and could be coming from their back even though they don't have back pain. So that's another thing to consider anytime someone comes in with leg pain, right? We talk about the same thing with hip issues, hip pathologies in pediatrics of someone comes in with knee pain, we always have to assess the hip, right? It's very uncommon in kids. So it's only about 1% to 2% of total cases of back pathology in the clinic, but it still happens. There's a lot of different reasons it can happen. I'll talk about that next slide, but it's really, really uncommon. Typically, we're going to see it in the glute, posterior thigh, calf, and occasionally in the foot. And then constant low back pain. I like to talk about this one because I think it's really important from a primary care standpoint. You guys are the first line of defense against some of these things. And so I really promote this, and I'll explain to you why. But generally, constant low back pain is going to be pain involving the lumbar region that doesn't change with activity or position. So first thing I'm always asking a pediatric patient that walks in the door, whether it's back pain, hip pain, knee pain, anything like that, is, does it change, right? Can we change it with activity? Does it change with movement? Does it change with position? If it doesn't, I'm sending them right back to you, right? It's very concerning, does require a referral back to a physician, generally imaging, and we're always looking for those other red flag symptoms that come along with it. So kind of anatomically, what are we generally talking about with these different types of low back pain? So from a mechanical standpoint, generally it's facet irritability. I like to describe it as kind of jamming the knuckle of your spine, right? Again, we see these in a lot of extension-based sports, gymnastics, football, you get tackled backwards. So we tend to see it a lot in that. Running can start to irritate it if they're not as strong in their trunk. We're always gonna rule out spondylolisthesis and spondylolysis. Again, this is probably really, really, really common when we see extension-based pain in pediatrics. It's almost, in my opinion, almost always some form of spondy. Just in different variabilities in terms of severity. And then occasionally there's going to be muscle strains. We'll see muscle strains in kids more so than we see them in adults. Muscle strains are actually really rare in adults. It takes a pretty high velocity activity, and kids are generally doing more high velocity activities. So occasionally we'll see those strains there. Low back pain with radicular symptoms, we're generally looking at disc related or nerve root related issues. But it can be inflammatory. Inflammation in the spine, spondyloarthropathy, those types of things can create inflammation that could create these radicular symptoms. We're generally going to see it more related to axial load in sports. So again, tackling, those types of situations. And then typically herniation in the lumbar roots is going to create those lower extremity symptoms. And then the constant low back pain, again, giant red flag, concern for oncological or rheumatological issues. Generally, it's going to be, if we're talking about rheumatological issues, those are going to be better with inactivity, worse with inactivity and better with activity, right? So if a kid says, it hurts in the morning, I wake up, my back hurts, and then I start playing sports and it feels good, it's actually a concern for me. I don't like that, right? If there's no concerns on imaging, then we can consider yellow flags, right? Is there a socioeconomic or a psychosocial piece to this that we need to look at as well, outside of just the structural or strength issues that are coming? I'm a big pusher for red flag stuff. My son had cancer when he was 4. He was treated across the street. So his primary care physician argued with us a lot on it and wouldn't do imaging, wouldn't check it out, wouldn't look for it. So I'm a big proponent, and I'm spending this time to talk and say, if you're concerned, if there's any concerns that don't seem normal, especially if PT is sending it back, please listen and please do the imaging, because I think it's really important, right? So how are we looking at these different things? How are the common pain reports with patients that are coming in? So if it's an acute back pain, if they say it came on suddenly, generally we're talking about trauma or infection. Infection can be a little bit slower, can be a little bit more of an insidious gradual progression. But generally, if it's acute, we're talking about these types of situations. Insidious, again, we're talking oncological, inflammatory, maybe biomechanical. We talked a little bit about scoliosis, and I was happy to hear Ishaan say that pain's not usually a big indicator early on. We don't see a lot of pain from scoliosis in these early patients. Even later in stages, as they get into adulthood, a lot of patients come into the clinic and they say, I have scoliosis and it's gotten worse. And we say, well, your curve hasn't progressed, right? But you've gotten less active. So everything is demand versus capacity in tissues. It's a big piece that I always talk about. And as we get older, we get less active. We tend to end up doing things like sitting at computers and sitting in front of televisions and trying to just relax because we all have kids and we're tired and we have jobs and we're tired, right? And we're not out there as active as these kids are. And so it creates these changes. So when we talk about scoliosis or we talk about biomechanical changes, generally it's because of activity related stuff more so than true anatomical variability. Localized pain, so we can talk more about these fractures, things like spondylolysis or spondylolisthesis. Facet irritation can definitely happen there. We talked about the mechanical low back pain. And then bony lesions, right? Again, looking at those red flag symptoms, sometimes benign, sometimes malignant. We always have to look at them and see, are there other red flags coming with it, or is it just localized? Okay. And then generalized, kind of just it hurts everywhere. Generally gonna be more muscular or inflammatory. All right. So what happens when they come in to see me, right? Who knows? It depends, right? They start asking me random questions about my blood test. How many do you have? I don't know. First questions I'm always going to ask, when did it start? It's an important one. We're looking at timelines, right? How did it start? Was there an actual mechanism for that back pain, or did it just kind of come on? What are the ags and eases? Those tell me a ton. Pain descriptors, again, we talked about kind of how those can define what we're looking at. The pain number and the smiley face. I can't stand the smiley faces. I never know what smiley face I am when I hurt, right? So a lot of kids get frustrated when you see that. So I like pain descriptors. Pain descriptors are more important than the actual number or the look of it. Them telling me what it feels like tells me way more than anything else. Impact on daily activities and quality of life, right? And again, you're looking at the yellow flags here as well. What's this back pain keeping them from doing? Is it affecting their schoolwork? Is it affecting their ability to be on a team? Maybe they didn't make a team because of their back pain. Is that also a yellow flag? Are we looking at some biopsychosocial stuff there? What does their day-to-day look like? And then any additional symptoms, right? Is there anything else we need to look at? From an objective standpoint, we're always looking at observation. Again, kind of looking for any deformities that we see. Trunk active range of motion, plus and minus overpressure. So giving them a little extra pressure as they bend forward. Does that increase it or does it stretch it more? What happens when we go backwards? Quadrant tests and stork tests. I'm going to show you stork tests here in a second. Those are great for looking at extension-based irritability, so facet or spondy. Straight leg raise tells us a lot about two things. One, the nerves, and two, the hamstrings, right? So we can take the nerve out of it by doing a popliteal angle test. We're going to put them in supine, put them in that hook line position, and then straighten the knee slowly and see how restricted are those hamstrings. Kids are generally pretty mobile and generally pretty good about being flexible, but every once in a while you see some hamstrings that are pretty short, pretty tight, right? And so we need to make sure that we're addressing that. Hip range of motion, I think, is really important. We do know that low back pain is very well correlated to hip internal rotation deficits. So taking a look at the hip rotation range of motion will tell us a lot about how much stress they're putting through their spine. Again, all of this stuff is demand versus capacity, load versus capacity. If the brain processes that load on that tissue is too much, it's going to set off the alarm system. That's going to be pain, and it's going to send in the guards, which is going to be the muscle spasm, right? So if the hips don't do what they're supposed to do, we're going to translate that force up into the spine, and now you're going to start to see a kid with back pain. Faber is important, looking at that. So flexion, abduction, external rotation position. It tells us a little bit about the hips as well. Is anything coming from the hips? And it just gives us a good idea of what the kind of SI joint irritability looks like. And then hip and trunk strength and endurance, always important. We look at it in everybody. But kids, are still growing. They're still trying to figure out their bodies. My kid grows taller faster than he grows wider. And so he's still trying to figure out what to do with his limbs, right? And so trying to understand where their strength is at and where their endurance at is important, and then connecting that back to the activities that they do. Are they a distance runner where they have to have more endurance? Are they a baseball player where they have to have good strength and stability around their trunk? What does it look like? And then what does their gait look like? Gait I have a question mark next to. Again, I can get on soapboxes about how we assess all day long, but I think gait is variable. Every kid walks differently. Some kids have a little bit of toe out. Some kids have a little bit of toe in. How much of that is pathological and how much of it is not, right? And so always looking at that kind of as what's their normal versus what's abnormal, what's contributing to their symptoms, and then what's just this kid being this kid, right? So stork stance is an easy one to do in the clinic. It's really good at trying to look at what that extension-based irritability looks like. It's okay for sensitivity and specificity. It's not great, but it's good enough for me to be able to do in the clinic to get a good idea of what they look like, both from a balance and a irritability standpoint. So the idea is you stand on one leg, flex one knee up towards the chest, and then you perform hyperextension of the spine. Usually you want to make sure you're kind of standing nearby, because if your kids are anything like my kid, they'll just lean all the way back and then think it's funny. So what are we looking at in terms of spondy? So just to review your med school stuff, the pars interarticularis is where that fracture happens. So spondylolysis is where there's a fracture there without any movement of the vertebra. And then when we get into a spondylolisthesis, there's actually a forward slippage of the vertebra there. So I see these fairly regularly. They're not uncommon, unfortunately, especially in athletics and in more specialized athletics. So Dr. Pandya is going to talk to you guys obviously always about specialization in sports, and we talk about it a ton. I tend to see these more in kids who are doing extension-based activities over and over and over and over again, right? So what do we do? How do we treat these, right? For patient education is a big piece for me. Tissue irritability reduction has to happen. We got to control the symptoms so that they have more tolerance to those activities, and then also so they have more buy-in to the exercises, right? One of the hardest things for treating kids as a physical therapist is keeping engagement. It's hard with adults, it's really hard with kids, right? So you've got to make it exciting, you have to have some engagement. And both from a pediatric and adult standpoint, giving those irritability reduction exercises, it gets buy-in, right? If I do an exercise that feels good, I'm gonna wanna do that exercise. If I'm just doing a bunch of strengthening that I don't really like and it's boring and it's literally that, or I could go outside and play with my friends, I'm always going to choose going outside and playing with my friends, right? So we have to give them something that feels good and then integrate that into their kind of strengthening component. What do we talk about with patient education? So activity modification is a big one. What are they doing on a regular basis? Are they sitting a ton playing video games, right? Or are they out playing sports 16 hours a day? What does that look like? There's a lot of extremes with pediatrics these days. So we have to make sure that we're looking at those activities and modifying for what's affecting them. Load management, it's a big topic of conversation right now, right? If you're watching basketball especially, everybody's talking about wanting to see LeBron James play and he's sitting on the bench every once in a while. Load management's good, right? We like load management. It allows us to progress gradually. This is really hard in collegiate athletes, right? There's generally time constraints. I don't think I talked about it, but at the beginning, I work at Cal as well. I work with the athletes over at Cal. And load management and load progression is one of the hardest things we have to talk about because everybody wants to get back next week, right? And there's usually a big competition next week that they need to get back to. They've got 4 years that they've got to be able to get this in. This year's a big one, Olympic trials, right? So we've got athletes that are going to Olympic trials. What happens if they get hurt and in 2 weeks they have to leave? So all of these things, this understanding of progression and education on progression and how if you do it right, you're going to get back faster. If you do it wrong, it's going to take you longer. You're going to keep getting this irritability. Super important. And I think helping them understand that, why they're doing the exercises they're doing and when they're doing them, really key. And then looking at variable stresses and activities. Again, I talked about that specialization piece to it. really trying to get kids not to specialize early, getting them to do things that vary the stresses on their body is so important. Position modification, so sit-stand transitions. We talk about this in adults, we have to talk about it in kids now, right? Every kid has a computer in school now. They're studying a lot. Luckily, homework's not as much anymore. But just trying to get them to sit and stand more regularly if they're doing their homework, not sitting for hours at a time. They have to sit in school. They have to be able to do that. So can they stand up every once in a while? Can they move around? Can they get outside, run around a little bit? Just trying to stay active. And then future adjustments. So exercise consistency. If you don't want this to come back, what can you do long-term to try to keep this away? Staying consistent with those exercises. How do we keep it consistent? For me, it's a low number of exercises, 1 or 2 things that they can do consistently rather than 20 that they'll do for a day, right? So we really want to make sure. I know I wouldn't do 20 exercises that are the same for the rest of my life, right? No matter how much my back hurts. So I really want a small number. And then progressive activity changes. So what does that look like over time? How can you make that more exciting? How can you make it more of a progressive increase in their load? So can they go and do exercise classes? Are there sport specific stuff they can do? Do they have an athletic trainer or a strength and conditioning coach at the school that can help them progress that activity? All those things are really important. And I think the interprofessional piece of that, working with athletic trainers, is really important. All right. So what are my big 3? Again, I like small number of exercises. So I gave you guys 3 of my favorite exercises for flexion-based pain and extension-based pain. These do carry over every once in a while. It's not perfect, right? There is no cookie cutter approach to this one hurts when you bend forward, so you always do this. This one hurts when you bend backwards, so you always do this. Sometimes people hurt both directions. Sometimes people only hurt with rotation. So this isn't perfect, but it's a couple easy things that you can do. You can give just pictures in the clinic to be able to start getting patients into these both tissue irritability reduction activities and strengthening activities. So I'm going to show you some pictures. Flexion-based pain, generally we talk about going into extension, right? So just prone on elbows is great. Just kind of gradually loading it up. I'm not a big fan of the full push-up. That's a pretty big hyperextension through the spine, and most people just don't tolerate it well. You can turn a flexion-based pain into an extension-based pain. So usually they don't want to get away from me, not come back to me for more things, right? So trying to do it gradually and slowly. Lower trunk rotations, where just when they wake up in the morning, they can do some gradual rocking from side to side. When they go to bed at night, they can do the same thing, right? You can help them out. Parents can kind of move them from side to side just to help, but it's just a nice, gentle rocking thing that they can do in bed. And then quadruped rocking as well, gradually loading towards that flexion-based position. Again, we talk about load progression, right? This is the same idea. Rotation's often involved in these pains. And so we talk about gradually putting them into those positions of irritability to desensitize that tissue. Extension-based pain, everybody loves a child's pose, right? It's like favorite exercise ever. It's called child's pose for a reason. We give it to children, right? Cool. Hip figure 4 position. So I like this one a lot. You can actually adjust it to put the hand down closer to the hip, and they get a little distraction through the spine. Feels good a lot of times. But again, stretching those hips out, making sure that hip range of motion is affected, and then just grabbing the knees, right? Happy baby, right? Another yoga pose. It's called happy baby, right? Babies are happy when they do it. So that kind of knee to chest position is really nice for calming the spine down with extension-based pain. And then when we talk about stabilization and strengthening, right? Again, big 3s. What do we talk about for flexion-based pain? The swimmer, right? It's kind of exciting. Not really, but it's as exciting as it gets with PT exercises. So just laying down, alternating arm and leg lifts. Don't have to lift high, you just have to come off the ground. We're really trying to target multifidi with this exercise. Multifidi weakness and atrophy and fatty infiltration is something that tends to build over time. And we know it's really, really correlated with low back pain. We talked about that with that NASA astronauts as well. And so trying to get those multifidi engaged and stronger is really important for long-term management, especially when they're going out and playing rotation-based sports, which a lot of sports are. We really want to make sure that that's coming into play. Bridges, I like to add a band just because it's something a little bit more exciting than just lifting your hips, right? Try to make it a little bit more exciting in different ways, but giving bridges, driving through the heels allows you to kind of turn the volume up on the glutes, turn the volume down on the hamstrings, right? If kids are cramping in their hamstrings when they're doing it, they're definitely not going to want to do it. So just trying to increase the volume on those glutes a little bit. Bands and dragging through the heels can help with that. You can progress it towards a single leg bridge. I really try to progress kids towards single leg activities and single leg biased activities because if you have one side that's a little bit weaker than the other and you're always doing two legs, you're never going to catch up, right? So you need to make sure you're addressing that. Bird dog is another kind of fun one. I use fun very softly in physical therapy. We all know it, right? But the idea of a bird dog, again, trying to get some of that rotational stability in the spine along with the sagittal stability of the spine. It's kind of fun for kids. You can give them a band, you can give them a ball to hold, they can throw it when they reach out. There's lots of different ways you can make it fun. And if you have a hard time, send them to us. We'll throw stuff at them all the time. And then extension-based pain. I like the anti-rotation press. Again, talking more about multifidus. Plank progressions are great. Usually kids are good with planks. They can do their homework while they're in a plank, right? And then side planks. That last version is really hard, so I don't expect most kids or adults to get to that point very easily. But lots of different progressions you can do and lots of more exciting stuff, right? All right, that's the physical therapy side of things, right? Thanks for having me, and I'm sure we'll have some questions at the end.
All right, thank you very much to our speakers. We'll open the floor to questions.
Yeah, I'm curious if you could talk about what you think about the Schroth method, or whether you think that either from PT or from because I know it's very common in Europe, but in the US it's not like there were 4 practitioners within 200 miles or something. Oh, thank you.
Yeah, I give a little bit of kind of the medical and surgical context, and maybe I'll hand it off to you for some physical therapy pearl. So yeah, I mean, Schroth is something that we often get asked about, and if you look at the literature on Schroth, it's a little bit unclear of what the indications are and also what the efficacy is. And so I tell families, right? So everyone at the end of the day, it's a little bit of like figuring out what the family believes in and what is going to be right for that child. And for the area that we serve, oftentimes these kids are very active and they want some activity-based treatment as well, not just a sedentary thing like a brace, right? And so I oftentimes will advise that if if the family thinks that's going to help them in terms of like just being able to be more compliant with their bracing. And the other time I will use it is if pain is sometimes a component in addition to the scoliosis. So we do have Schroth therapy offered through our system now at UCSF. And so, you just have to provide some justification of why you're doing it. And then the last thing I'll say is I always tell the families it's not a substitute for the brace though. So if oftentimes these kids are the ones that are bracing and they want something else, and I always tell them that it's okay to do it as long as it doesn't compromise on the bracing hours as well.
I knew we were going to get this question. So obviously my talk wasn't on scoliosis specific physical therapy, but again, like Ishaan said, with Schroth, we know that the research doesn't really support it higher than general exercise. General exercise has been shown to be pretty equally effective at treating scoliosis-based discomfort. We also know that Schroth and the other schools, there's about 7 schools of scoliosis-specific rehab, they don't change curve progression. So again, that bracing is still really important. It does not reduce curve progression. It just helps stabilize and kind of help with discomfort and functional tolerance. Schroth, from my standpoint, again, now I'm gonna get into my opinions, but it's a very intensive program, and trying to keep kids engaged in physical therapy, like I harped on, is already difficult. And so when you have a very intensive physical therapy program, very specific exercises that they have to do, there's a lot of them, it tends to be a lot of physical therapy, it can be hard to keep engagement. And so when I see studies that show no real change in progression, not really different than general exercise, and I know I can give exercises to these kids that are going to be a little bit more engaging, I tend to lean that way. I have colleagues that are huge Schroth fans and do Schroth method. So I don't think it's horrible. Like we said, if you can get kids in activity, no matter what it is, I think it's good for them. But from my standpoint, it's really hard to keep kids engaged in Schroth long term. I treated a lot of adults that went through Schroth early on as well, and most of them gave up on it after a few months. And so we see it pretty regularly.
There's, going back to the 100-year-old operation, manipulation for spine deformity is in the Hippocratic corpus. So it's 2,500 years. And it didn't work then. And if you want some evidence-based, or at least a good study, there's one from 2020, so it's not that old. And the authors are two esteemed surgeons, Herring and Tolo. They're household names in our field. And they reviewed the evidence for manipulative therapies for spine deformity. And the conclusion is there is no good evidence. But it's very popular. So I think it's one of those things where it doesn't harm, except maybe in that it occupies the kids' head. And so if it doesn't harm, then it's okay to do. But I would really be careful that I think we're selling this a little bit too hard. And it is a bit of a sales pitch because you're offering patients things other than big bad surgery. But I think we should be careful that we don't overpromise it. It's good, always good to do manipulative therapies of any sort. I mean, I'd like a massage at the end of every week because I'm exhausted, and I think that would be good for me, and I think that's okay. But we just got to be careful. And then please remember that patients, it costs to do this. It's not free, and it's not just time for the child, it's also resources for the family. The other thing I worry about is it sometimes delays, or it gives you an alternative to the brace or to an operation. You come back and you're 20 degrees bigger curve. And now the treatment is a little bit more complex. So we just got to be careful with it, just keep it in context.
Any more questions?
My question to Professor Diab. You talked to us about the tethering procedure. What are the specific complications that you feel like are very specific to this procedure? And what kind of patients that when you see them, you feel like this patient is more likely to get complications, given that many studies mentioned that there is high risk for pulmonary complications after tethering and like screw breakage? And thank you.
Thank you for the technical question. We'll try to give it sort of a simple, not too technical, don't lose the audience. The indications are for the growing spine, although it's being done for mature patients. So that would be one thing. So a patient who's growing, and that's your population, that's the kids that we're seeing. So growing child is the best indication. The complication profile is pretty low. And this has been published both by a study that was sponsored by the company under the direction of the FDA. So if the FDA is involved, it's going to be a good study because they're going to require it. So we can rely on the data. So I think the complication profile for tethering is pretty low. And overall, certainly not higher than spine fusion and probably lower than spine fusion. So for example, the infection rate is almost nil. We've done more than 200 at UCSF. We've not had a spine infection, but we have had spine infections with fusion. So, and then the nerve injury rate so far is nil. I don't know the case, which is fantastic. So it's pretty safe in that sense. And that's the dreaded complication, is a nerve injury. The implant failure rate is high, really high, way higher than spine fusion. And the main complication there, so implants, so you put in the metal into the spine, something happens. In the fusion case, a rod breaks or a screw pulls out, and you have to go back and redo it. That's relatively rare in spine fusion. It can happen, but it's rare. In the tethers, where we put screws in the bone, they don't have a problem. They don't break. They don't move, or very rare. But the cable, it's a piece of rope, that breaks. And so that's why you'll hear things like, well, the implant failure rate is really high. Yeah, the cable breaks, but the patient doesn't feel it. And they're not at risk. You just look at the x-ray and go, damn, the procedure didn't work. Now they're getting their scoliosis. And then for the pulmonary part, I think that's overrated. In our world, we talk about if you go into, so the way we do the tethers in the chest, the thoracic spine is in the front. Most spine fusions are in the back. And in our world, we talk about going into the chest and how invasive that is. But the pulmonary hit is temporary. There's no question. If you open someone's chest, they don't breathe as well as if you don't. Okay, that's pretty simple. But it doesn't last forever. They recover almost entirely within 2 years. So the recovery rate is well over 95%. Somebody wrote a paper that said it was 98%, say, at 2 years, whatever it is, but it's over 90%. You've recovered. And clinically, you can't tell by 2 years. So I think it's a temporary thing. And then things like deflating the lung because I've got to go into the chest, we've just not had that problem. I think just got to be careful. We know what the complication rate, we know what the problem with the tethers is, the cable breaks. That's the problem. It just doesn't work sometimes, many times. But other than that, I think it's okay. It's an okay procedure if it's the right patient.
Maybe I heard wrong when you were talking about spinal maturity, but for a person who has a 20, 30 degree curve, they might get a brace. I would call it not in that serious risk range. My understanding is in their 50s, 60s, the scoliosis really isn't a problem. What do we now know about these people as they're becoming adults? What do they deal with?
So for kind of the mild and moderate deformity, right, so 20 to 30 degree, we reliably think that does not cause an issue long term. So one is, if you again go back to natural history data, yes, there is some progression that happens even in curves below 50 degrees, right? But it's not a very significant progression that happens over time. So we don't generally think that, say, again, to your scenario, a 20 to 30 degree curve, likely is, I routinely will tell families, I'll look at them in the eye and tell them this is not going to have an implication in life, generally. Now, there is a study that suggests that curves over 30 degrees after skeletal maturity, so once you're an adult, that there is an increased risk of back pain in that population after maturity. But as we all know, that is confounded by so many other factors, right? Like whether you smoke or not, and how big you are, like what activities you do, what Daniel talked about in his talk. So I, again, don't use that as a justification to push an intervention, but I do let them know that these are things to think about as you get older, is what kind of lifestyle you're going to choose and things like that.
I think the 20 to 25 degree curve ranges I see a lot in the adults, and they'll come in and say, this hasn't been a problem for me, but now my scoliosis is hurting, right? So it's probably one of the most common things I hear with adults who have been diagnosed with scoliosis at some point. They never knew they had it before. They come in, someone does an x-ray, they have a scoliosis, and they go, oh, well, that's your problem for the pain, go see PT. And what I try to tell them is, you've had this for a long time. All of these start in pediatrics. And the thing that we know is that generally these 20 degree curves don't really progress beyond adolescence. So we talk about the frog in the boiling water analogy a lot, which is a terrible analogy, I like frogs. But the idea is if this has been gradually happening over time and you've had this for as long as you have, it's not scoliosis that's causing your problem. It's the inactivity, it's the deconditioning, it's the changes in positioning and the prolonged positioning of the load to those tissues that creates the problem. And if we can adjust that just like we do with any other adult-based back pain, we can usually make a pretty big difference. And so once you get that kind of education piece to them, usually it's pretty easy buy-in of like, oh, okay, great, that's fine. But I hear it a lot in that 20 degree area.
A lot of the conditions that we treat in pediatric orthopedics, likely for you all, can be bimodal. But if you've got a pediatric lens, you're not going to see the other spike. But there are many conditions that accelerate or come to attention or erupt during the pubertal growth spurt. then they calm down, and then they come back at you when you're older. And so I think if you really want to kill this answer, just remember that probably when the patient is 60 or 70, theoretically you would start moving into what's called degenerative scoliosis. So you've got idiopathic scoliosis. A teenager, minding their own business, suddenly they've got a spine curve, what the hell. But at some point, joints are going to give. It's not just your knee. The joints in your spine can give as well. And if they start on a slope, they're going to start falling down that slope. And so the adult spine surgeons see a lot of degenerative curves that were not much in childhood and now are just beginning to fail and hurt. And that's their world of business. So I agree with exactly what you said, which is just leave it. 20 degrees doesn't matter. 30 doesn't matter. Even 40 doesn't matter. It just doesn't matter. But it might matter when you're 65 or 70.
I think there was a question up front.
Just a simple question. When you were talking about ordering spine x-rays, so as a physical therapist, I'm curious if I am just generally in the community, how would I ask the right questions of where they're going to have their x-rays ordered to get what you would be looking for?
Sure, yeah. So, I think from a technical point of view, the things you want to order is typically 2 views, right? So you want a standing, first of all, you want a standing x-ray. You don't want these to be supine, typically in an idiopathic patient who can stand. So you want a standing x-ray, 2 views, so a PA and a lateral x-ray typically. And then, I always think of it like, where is it going to be done and who's going to be reading it? And so, and again, I don't mean to be biased, but obviously I am a little bit since I work here. But I think going to a place that does it often, right? And you have a radiologist who reads pediatric scoliosis x-rays, because at the end of the day, you're not going to have one of us looking at it. You'll probably have a radiologist who may not see that many scoliosis x-rays. And so those are the 2 things I look at or I think about when, I think about like ordering x-rays or, if someone asks me a question, where should I get an x-ray?
Yeah, the one thing I'd add is if you want to order x-rays, standing, totally, obviously agree with that. And in our world, we do a lot of weight-bearing imaging. So even a foot, if a child hurts their foot, try to get a standing, a weight-bearing foot, because it looks different. And weight-bearing is the functional position. That's what we're looking for. But also I'd add in the spine is, if you could, ask for full length. Those 2 words, because we're trying to see the whole spine. And what we do get a lot of times in the clinic is a spot view. We can't see the whole thing from end to end. And we can't see it relative to, let's say, the pelvis. Now, we're not asking for real technical stuff. I think there is utility in getting local community-based x-rays. So don't just say, no, we're just going to always send it to the main center. But if you could, ask for those things. So standing and at full length would be helpful. And that's another thing about that is it sort of weeds things out, because places don't do full length films. So it kind of helps you decide, well, maybe that's not the place that should be getting the x-rays anyway.
Are you thinking too, like how to discuss how to ask for one from a PT standpoint? Yeah, I think that's one of the challenges, right? Because we can't order imaging, right? And so from my standpoint, I'm lucky I get to work at UC. I can just send a message and say, hey, this is what I'm concerned about. But I think in terms of verbiage, like if you're asking for imaging, have a rationale behind it, not just, they might have scoliosis, right? It might be like, I'm concerned about curve progression. We're seeing a fairly heavy curve, and we want to make sure that bracing isn't going to be indicated for this patient to try to stop curve progression, something to that effect. Because otherwise, ordering imaging is kind of like, do I really want to, or do I not? And so it kind of can become this battle. So I think there's got to be that justification from our standpoint of, this person's not going to just do okay with conservative management. I want to make sure that this doesn't get worse and progress over time in this pediatric patient. Does that make sense? Yeah, good.
I would just add that also helps us as primary clinicians in discussing it with the parents, because more and more parents know, well, why are we doing that? I don't want more radiation.
Yeah.
So that when we have that piece of information from the physical therapist, it helps us a lot.
But I just add 2 more things. One is going back to that algorithm I showed, right? When you think about trunk rotation, so what you're measuring in a scoliometer, not every single little bit of asymmetry you see on Adam's forward bend needs an x-ray, right? And so that's important to remember, like there are guidelines of which ones need it. So typically like more than 5 to 7 degrees of rotation needs an x-ray. And then the other is if they do get it elsewhere, right? I mean, thankfully, like a lot of us who live in the Bay Area, there's a lot of places you can get it, but if they're coming from somewhere else, just remind the families that they should get their imaging on a CD, right? At the end, like it's remarkable to me how much even in 2024 in the United States of America, everyone thinks that we have access to everything, but we don't in healthcare. And so it's just important to remind families, just always bring your x-rays to the time, to the evaluation.
All right, we'll pause with the questions.
I have a question.
Okay.
I have a question for the audience because I'm sort of curious. So first of all, I love coming to these talks because you guys are the front line for us. So thanks. And I'm always sort of interested in your experience. How much are you all hearing from families? Because you brought up this thing about radiation. How much pressure is on you all about, I don't want the x-ray because I don't want the radiation?
Well, particularly for something like scoliosis, right? Like how much is that to do over and over and over?
Yeah, I mean, that's an issue, right? I mean, we're all struggling with that. And we're all under pressure to buy $1 million machines and such. But what about anyone else? I mean, is there pressure out there on you all that we don't want to get radiation?
I get more the opposite. Is they're coming in and they want you to do this and this
Yeah.
and this and figure it out. And I'm talking them through, whoa, we got to deal with, is it worth it? Are we going to get an answer that's going to give us information that's going to change the direction of the pathway we're taking? So, no, I'm talking them down.
Very interesting variability in patients, right? Because we get the same. We get patients like, are you kidding me? That's radiation and all that. And then the opposite is also true. Like, why are you getting? So I'm sort of low radiation guy. I get as few x-rays as I can get by with.
So if we see one that's not that, so here's a question, we're in the autistic dude access, and we're like, okay, it's a little, you're 11, 12 years old. Do you not want us to get any baseline studies at all? Or just be like, we see it come back, at what point do you get that initial set of films?
That's a difficult question, right?
So again, the data will go back to like what you measure, right, on your scoliometer. So the rule of thumb generally is about a degree of the difference on a scoliometer is roughly about a 3-degree coronal deformity. But that data is also very questionable because it's not a very linear relationship. And so that's why the 5 to 7 degree on a scoliometer comes about, is because that kind of corresponds roughly to a 15 to 20 degree curve. And so that's where I think, quantifying it probably is a good idea, right? And so not all of us have a scoliometer, but you can use, we talked about this before in different settings, but like your iPhone has a scoliometer, like it has an inclinometer, right? So you can actually kind of use that as a proxy to tell you how much rotation you're actually seeing when you do a forward bend test. And so if you're going to hang your hat on something, you can use that. And then the next part of your question would be like, say I get an x-ray and it's an 11-degree curve, does that patient need to be referred to come see an orthopedic surgeon? And then that becomes a little bit of a shared decision-making process with the family, right? So again, full disclosure, my wife's a general pediatrician. And oftentimes like we talk about this and it depends on the family. Like some families want to go see a specialist because technically they have scoliosis, they have curve over 10 degrees. But some families are like, you know what, I'm actually okay. I don't want to drive 3 hours to go see them. And so, yeah, it's probably okay if you wanted to repeat an x-ray in a year and see, is there a change? And if there's a change, then refer them, right? There's no right or wrong answer to that.
If we send them to you and say it's borderline, they decide if they want an x-ray, because that's fine.
Borderline meaning like
I don't know if you think it's appropriate, you have to do it, let you guys decide if you want to.
at the end of the day, that's why we exist, right? And so
That's so he's being way too generous. No, believe me, it's not just that we don't want to see patients who have borderline. It's also the patients. I mean, a number of times they're like, "Are you kidding me? I drove 3 hours. I waited an hour for you to tell me it's not a problem." I just don't think there's a right answer to this. I mean, yes, that is why we exist, and we will be hospitable and see these patients. But then they get mad. So, I mean, I think a simple, at least one view X-ray is low radiation, even if it's not done great. It gives you a sense of where you are. So sometimes it's helpful to at least get one view. And that helps triage. And then maybe you can always just call us too. You don't have to just say, oh, I just refer. And we can often see in some way from a distance and make that decision. I just worry about patients who come all this way and it's a massive letdown.
I'd say there's pain too. That might be more of an indicator, right? But if there's not, then same idea.
All right, I think this is a good transition to some case discussion. We have actual clinical cases that we're presenting, and then we can kind of discuss our approach or algorithm with each case. So this is a 15-year-old girl who came to us with scoliosis concern. The referral actually says 6 degrees of scoliosis, and it was just caught on annual physical. When we spoke to the patient, she hasn't had any x-rays done before, so we're assuming that number was from a scoliometer assessment. No pain. Family hasn't noticed any asymmetry or changes in her back. And so, because of that type of referral and family wants a definitive diagnosis, we did obtain x-rays for this case. So just quick show of hands. How many of you think this is scoliosis? Great. What if the radiology report comes back and, a lot of times our primary care colleagues don't have access to imaging. And so what if the radiology report comes back and says 6 degrees of, levo scoliosis? How many are gonna just observe this in primary care, and how many are just gonna observe this in primary care? Great. How many are gonna send for a referral? Okay, fair. All righty. Can we get some comments from our speakers? Thank you.
Yeah, that's probably straighter than my spine. Again, 10 degrees is the usual cutoff for definition, right? So again, going back to practical knowledge, that's a number to know. And so those are the ones that would, if it's over 10 degrees on your Cobb angle greater than 10 degrees, then you call it scoliosis, otherwise you don't. So otherwise it's spinal asymmetry if you're trying to put a label on it.
One thing, I don't know if primary care docs use this, but we talk about Sutton's Law. You guys ever talk about Sutton's Law? No. Willie Sutton, the bank robber from Chicago, who was asked why you rob banks. That's where the money is. We're using a spirit level. So a scoliometer is a spirit level. So we're going to Home Depot to get a piece of Dacron. Just go to Home Depot and get a spirit level. The thing that you use to hang a painting in your house. It's the same thing. There's nothing fancy. It has scoliometer written on it, but that's what it is, right? And the bubble goes a little bit to the side if it's not horizontal. So that's a secondary measure. That's a measure of rotation. But you can always just feel the spinous processes and see if they're straight or not. And I'll do that so the way I sort of see patients in the clinic is I make the mother stand behind me and I examine the spine so she sees everything I see. And then she's engaged, or he. And I'll take the spinous processes to my fingers and I'll just go right down. And I'll say, is that curving? Rotation, there can be normal asymmetry. I think everybody in this audience will probably know of one asymmetric part of their body, whether it's hand, eye, limb, what have you. So there is some normal asymmetry, but you can back yourself up by just feeling spinous processes. And you can do it also when they bend forward, because they arch and they expose the spinous process. And you can look right down the spine and you can see that it doesn't deviate very much. So I suspect in this patient, there was probably some chest asymmetry. Gives you a 6 degree or something, or what have you, whatever it came on an x-ray. But if you had made them lean forward, you probably could have just followed that it's pretty straight. And that's, why not go right there where the money is?
Can you address our spinal muscles? Sometimes I get confused with my scoliometer out and behind, wait, I keep checking your feet, and I'm like, this is higher than your triangle, what's the deal with that?
That's why it's not perfect, right? Because you can have paraspinal hypertrophy or hypertonicity in there. Again, we talk about that guarding effect of if the brain's processing something a little bit differently, if they have a little bit more discomfort, usually they'll have a little bit more hypertonicity in that area. So that's why it's not perfect. You can't take those muscles out of it. You're gonna get the muscles in there. There's no way to avoid it. So you're probably gonna see what looks like a larger curve than there actually is. And so again, that observation piece is really important. You're looking at it and going, what does that feel like? Does it feel soft? Does it feel like rib? What does it feel like? And you can tell the difference between paraspinal and a rib when it's elevated. And so that's why for me, when I'm in the clinic and I see a curvature, I go, okay, it's there, but how much is that affecting them? And why is that paraspinal hypertonic? Is it trying to protect something? Is it sensing something that's irritated more so than anything else? But you can't take it out.
And then can you comment on follow-up? So since a lot of our participants are just going to be following this on their own, do we think that at 15 years old and 2 years post-menarche, do we need to repeat these x-rays? Yes or no? No. Okay. But if, for example, the patient was, say, 10 years old and it was spine asymmetry, would you say otherwise?
I would say unknown for that group, right? So could it, I always think about this, I'm like, okay, could this just be really early idiopathic scoliosis, right? And it could be really young, and it could be, right? At the end of the day, some curves start at some number, right? So that's where I think, again, the physical exam in your office, and I know, again, I try not to add too much to the plate that you already have, which is very full, but I think that's the end of the day, is every year is kind of doing it more objectively as you can, so that you have, again, that this does look different from last year. And I would say some of the harder ones are actually more proximal thoracic curves, so the ones that are much higher towards kind of the cervicothoracic junction. Those are oftentimes the harder ones to screen for. And actually some of the lumbar ones are easier because you oftentimes start to see some waist crease asymmetry. So even though, yes, objectively look at them the scoliometer number, but those are some of the other things I look at is, help looking at the shoulders, looking at their waist crease as well.
And do it every 6 months or so. It's a slow moving thing. Yes, sometimes scoliosis comes out of nowhere, but those are the exceptions. So you don't have to bring back the bond. Just come back in 4 to 6 months. Take another look.
Even a year, probably.
Yeah, that's what I mean. I'm trying to diffuse it for you all, and just don't worry about too much. You have time. This is not cancer. You need to see it immediately. It's slow.
All right, thank you. This next case is a 12-year-old girl who came to us for scoliosis evaluation. The Cobb angles measure 15 degrees for the thoracic and 15 degrees for lumbar. This is actually done locally. As you can see, it looks a little different from our image from last slide, but it's acceptable. It's a standing x-ray and it's an entire spine, and so it's acceptable. What algorithm would we use typically for these patients?
Yeah, so just a comment on the x-ray, right? So I totally agree. The whole spine's included, but the thing that's not included is the pelvis, right? So if you go back to what we were talking about, right? Skeletal maturity as being an important factor in determining the risk of progression. Yeah, I can kind of get a sense, this kid is 12, obviously we'll know menarche status, so you can ask the family or ask the child. But that's something that's not included. So oftentimes it's helpful to have the full pelvis so you can look at the Risser sign. In this case, clearly meets the definition of scoliosis, so has that diagnosis. Oftentimes, if they're coming to see me, I will continue to follow it then. The frequency of follow-up, so if it's an initial evaluation, I'll generally see this kid back in about 6 months. And in 6 months, if there's no significant, and if they're certainly 12-year-old, probably premenarchal or maybe premenarchal, then I will certainly see them back in 6 months. If there's no progression, then, and they're postmenarchal at that time, then I may think about spacing out the follow-up a little bit more than 6 months, just giving the radiation considerations. But that's my usual algorithm.
If I could put a request, life is a circle, and you start, you come into this world naked and you exit naked. And we started off with the Tanner Whitehouse assessment, and then we've gone through a million different ways to measure maturity, and I still use the Tanner. So in addition to menarche, if you would remember when you send us patients to just tell us what Tanner stage they are, because we're not measuring it. What we do in our clinic is we give them a chart and say, which one are you? We're not going to examine them for that, but they can usually tell. But if you would let us know that too, that's helpful, because a patient who comes in with that, just like Dr. Swarup said, we don't see the whole, the whole pelvis for maturity indications. But if they're 10 or 0, actually the boy I operated on Tuesday, I mean, he is so immature. He's 14, but he's so immature. And so that's helpful to us.
All right. I think we have time for one more case. I think this is Dr. Swarup's case. Do you want to talk about it a little bit?
Sure. I don't recall her age when I first saw her, but the X-ray on the left is probably the initial X-ray. So you can see she's got a lumbar curve, right? So probably waist crease asymmetry, and you can already see that on the X-ray, soft tissue shadows. I think she's probably like a RISR 1 or 2 when she first came to see us, so we did a brace. And you can see her in brace. So this is another common question we get: is the brace supposed to make the spine totally straight? And the answer to that is I don't know, right? But it should be better, right? And so some people say 50% correction is probably what you're shooting for with a brace. But I don't know if we have any orthotists talking.
Not today.
But you know, sometimes you can get what you get. And so I oftentimes tell families it needs to look better and it needs to be comfortable enough so that the child can wear it for 18 hours a day, right? You can only make the strap so tight until whoever they are, like the person who's wearing it is going to not wear it. And so she has a reasonable brace, and then I think she was braced for about 1.5 years. And then that's her final outcome on the right, which is, again, doesn't make the curve go away, but it stops it where it is. So you take a 25 to 30 degree curve, which could progress in a premenarchal, skeletally immature patient, and you keep it there. And then going back to what we talked about earlier, this has no implications. They can go on, play whatever sports they want to do, be whoever they want to be.
So a lot of times we get these patients, they're typically, pubertal, prepubertal teenage girls with a lot of, hesitation towards bracing. And you did mention earlier that, we recommend full-time bracing. So how do you navigate those situations?
Yeah, I mean, this is kind of where I think, the patience is a virtue. Like, you gotta sit down and kind of talk. And I think a lot of us talking to teenagers is never easy, or pre-teenagers is never easy. But I kind of talk about it as being kind of a temporary thing. So I think the important thing to relate to them is you're doing this for a temporary period of time when they're growing the fastest. And I think that is really hard for a lot of kids to grasp, but it's important to kind of express that. And the other is you gotta sometimes just sit down in time and map it out for them, right? So you can wear it at nighttime, you can wear it out of school. That oftentimes is a big relief to kids because that takes away the stress of wearing it at school. But there are kids who do a ton of activities, and for them, I oftentimes tell them, look, I do this for a living, and I can barely tell half the time if we're wearing a brace or not. Like when you have a gown on, I can't tell. And so I try to figure out what the best schedule is for them. And I personally do tell them to wear it to school, and I tell them to wear it until, figure out what logistically works. And this is where the family and the caregivers have to have buy-in as well. So it's a discussion that they need to also be a part of. And figure out the best schedule for their child.
Yeah, brace wear is just difficult. It's the wrong time of life to put someone in some evil device. It's not something, yes, it is, you can certainly cover the flow, but it's to the patient, and this is a big, bulky, hard thing. So we just do our best, but we have to acknowledge the fact that it's stressful. And it's stressful on the child, it's stressful on the family. We also have to be honest that they don't wear it probably as much as we'd like. That's why there are so many studies with little brace monitors, because we're all trying to track them to see how much they wear it, but as much as possible. And I appreciate what Dr. Swarup was saying about making them wear it at school. I've sort of just given in because I've just been worn down, and I'm happy if the minute they enter the house, they get the brace, and then the minute they leave the house, they give it back to their parent. If they can just get that as the base, and then anything on top of that is sort of bonus.
The other thing I tell them is, right, a lot of us wore braces as children, on our teeth. It's way more conspicuous than a spine brace, right? So if you can do that at school and survive, which most of us did, then a spine brace is for a much shorter period of time and is less obvious.
All right, I think time is up for our spine session. Our speakers are going to be around for a little bit, so please don't hesitate to come up to them and ask any questions. We'll have a 25-minute break So please enjoy some food and beverage. Please visit our exhibitors on this side of the room. On the other courtyard, we also have one exhibit of our Pediatric Orthopaedics and Sports Medicine program. Please stop by. We have some pens and other freebies to bring home. And there's more seating area on that side of the courtyard. So we'll be back at 10 o'clock.